Logging into our live webcast called Tackling Concussions Head On. I'm Dr. Mark Proctor, a pediatric neurosurgeon and the director of the Brain Injury Center here at Children's Hospital Boston. You're probably aware that there's been just an explosion of information regarding concussions. There seems to be an epidemic of them occurring. The consequences of them are probably far more serious than we realized. And the science of concussion is just starting to catch up with the problem. Thanks to experts around the country, we are starting to learn more about concussions. Many of those experts are right here at Children's Hospital Boston. And over the next hour or so, we're going to work with them to try and give you information about the basics of concussion, separate the fact from fiction, and tackle the problem of concussion head on. I'd like to encourage you to ask questions about concussion throughout the broadcast by clicking on the Ask the Questions button on your screen. We'll get to as many questions as we can, and if we can't get to the questions, we'll answer them offline at a later time. Throughout the webcast, you're also going to be seeing video clips of one of our patients, Nick, and his mother, Kristen. Over the course of 3 years, Nick suffered 3 fairly serious concussions playing hockey. Eventually, he came here to see us at Children's Hospital, and he did very well. However, the family had to make the difficult decision to take Nick out of the sport for less aggressive non-contact sports. So I'd like to thank Nick and his mother, Kristen, for their participation tonight. Now we're going to move a little bit onto the basics of concussion. First of all, what is a concussion? A concussion is really any trauma-induced alteration in brain function. It's very hard to define concussion by any specific symptom or set of symptoms. Dr. Meehan, one of our sports concussion experts, is going to go over those symptoms more a little bit later on in the broadcast. But if you only took one thing out of tonight's talk, it's to realize that concussion does not have to involve a loss of consciousness. In fact, about 90% of concussion does not involve loss of consciousness. So any child that takes a direct hit to the head or a hit that rattles the head and then suffers symptoms, probably you can define that child as having suffered a concussion, and you don't need to see them lying out cold in the middle of the field to call it a concussion. Next, you should realize that the whole culture around concussions is changing. In July of 2010, here in Massachusetts, Governor Deval Patrick signed into law the Act relative to safety regulations for school athletic programs. A few important facts there is that now all students have to give a concussion history. There's required education on concussions, and most importantly, if a student suffers a concussion during a game or practice, they may not return until they're cleared by a medical professional. Here at the Children's Hospital Brain Injury Center, we support that law and the education that's part of it. Our goal is to set the standard for the comprehensive care of children with traumatic brain injuries via a multidisciplinary team approach that incorporates prevention, the acute, subacute, and chronic care, research, and family support and community reintegration. This can't be done by only one doctor or only one specialty. Here at Children's, we believe in the multidisciplinary care, including neurosurgery, neurology, sports medicine, emergency medicine, trauma, psychiatry and neuropsychology, physiatry and rehabilitation, radiology, and the nursing professions as well. We all work together to help your child. So we are there to help. If your child suffers a concussion, you can reach us at one easy phone number where you'll be triaged to multiple locations and multiple specialists depending on the needs of your child. And what will we offer your child? Well, state-of-the-art care is what we offer here at Children's Hospital. On the clinical front, we have the Think First Injury Prevention Program. Here at the hospital, we have a portable CAT scanner, an intraoperative MRI scanner. We have computerized neurocognitive testing, standardized balance assessments, vestibular therapy, and expert symptom management. On the research front, we're pioneering new imaging technologies, new medical therapies, new helmet technologies, and looking at what are the risk factors for long-term recovery. Next, we'd like to go to one of the videotapes of the Johnson family to introduce the patient perspective on concussion.
I felt like Nikki's concussions, interestingly, dovetailed with this kind of new wave of awareness with concussions and just a new approach to it. Ironically, the coach of the first hockey team when he got his first concussion was a pediatrician. And even he came to us. Nikki was long gone from that team, and and whatnot, but he knew that he had had another concussion and things were different, came to us and said, what could we have done differently? Would you help us write some sort of protocol for coaches to follow? And they're not, these are volunteer parents. They're not trained to recognize these things. Most of the coaches aren't comfortable holding an inhaler for an asthmatic, and let alone having a kid with diabetes on the team. So something that doesn't have a big neon sign on their head like a concussion, they just didn't know what to do.
We're now joined by Dr. David Mooney, who's the director of the trauma program here at Children's Hospital, to tell us why is concussion such a big deal?
Well, thank you, Mark. Thank you very much for having me here. And thanks to the viewers who are watching this and even watching it once it's been archived. It's very much to your credit that you're learning as much as you can about this increasingly important area for injury in kids. Child concussions in the United States are a growing problem. They've probably been around for some time, and most people have a memory of having a concussion as a child or knowing someone who had a concussion as a child, the importance of which wasn't often recognized. There's something in our culture about someone having their bell rung and getting up and fighting on, or cartoon characters or actors in movies who are knocked out with seemingly no long-term effects. And it's only within the past few years that increasingly people have recognized that these are a big deal, that concussions in children can lead to long-term complications. We don't really know how many kids in the U.S. have a concussion every year. We believe it's probably around 3.5 million kids every year in this country that suffer a concussion. We do know that about 150,000 kids every year are seen and treated in an emergency department for concussion. About 10% of those kids, or around 15,000 children, are admitted to the hospital simply for the care of their concussion. Most commonly, this happens in 10 to 14-year-olds, though it can happen in any age group in children. And it's unknown how many kids either don't seek care or seek care later on for post-concussive symptoms that may or may not be recognized as having come from their original concussion. I have to apologize for the data that's on this graph because to me, or in this table, this is a reflection of some of the problems that we've had with the field of concussions. It's such a new field that the closest information we can find to the ways the kids are hurt suffering a concussion is based upon the ways kids are hurt suffering a brain injury overall. There's such a big focus lately on sports injuries. But sports injuries are responsible for only about 1 out of every 6 brain injuries that children suffer. The leading cause of brain injury in a child is from a fall. Recently, there was a publication that 5,000 kids per year fall out a window. Many of those kids hit their head and suffer a brain injury in addition to their other injuries. Car crashes are a very common reason for children to suffer brain injury, and sometimes are the source of our most severe brain injuries. And sadly, abuse is still responsible for about 10% of the injuries that we see to children's brains, and then miscellaneous other causes. This graph actually shows the proportion of injuries per sport, the black line being high school sports, and the gray bars being college sports that are concussions. Not so many how many concussions occur per sport, but of the kids who get injured in that sport, how many of them happen, or how many of them are a concussion. In football, for example, around 11% of the injuries that happen during playing football in high school are a concussion. So about 1 out of 9 injuries that happen are concussions. Female soccer, around 15% of the injuries that occur are a concussion. To me, the point of this graph is that it shows that trainers, parents, participants in these sports, female soccer, male soccer, football, female basketball, need to be very aware of the symptoms, the evaluation and the management of children with concussions, because per injury that they see, a significant number of those will be a concussion. So in summary, concussions are a major source of injury morbidity in children in the United States. We're still coming to learn how many concussions happen, what are the significant long-term sequelae of those concussions, where children seek care, and what we can do to help prevent those.
Great, thank you, Dr. Mooney. We do have one question that just came in through the iPad here from the audience, and that is, why did we only recently realize how big a problem concussions are?
I think, to me, I believe it's because of the publicity that professional athletes have garnered. There have been a few really notable cases of professional athletes in the NHL and the NFL who suffered long-term problems related to repeated concussions. And I think there's been a trickle down now to child concussions. And to me, it's a little bit of the realization that dumb jocks might actually have started off as smart jocks, but because of repeated concussions, their cognitive function has deteriorated.
Great. Thanks so much. We're now going to go to another video vignette from the Johnson family.
We had caught him crying at 2 o'clock in the morning, and he'd been lying wide awake. And we'd say, why aren't you sleepy? Are you nervous about something? Do you have a test tomorrow? Are you upset? Did you eat something? And we went through every ounce of feedback that we could try and get out of him. And the reality was, he was still concussed. He kept telling us, my brain's so busy. It won't shut down. My body's exhausted. I feel like I've molded into my bed, but my brain won't shut down. So it was those sorts of things, like I said, in retrospect, we started to piece together. The light sensitivity, mild headaches here and there, a little bit of balance that was slightly off. If you saw it, you'd think the kid's got great balance, but we knew that compared to the old Nick, it wasn't the same. And then the delayed sleep onset was really the last straw. We said, you know, this is now kind of being a cumulative effect. You're exhausted all the time. Things aren't working. He wasn't reading as well at school. Something was up.
We're now joined by Dr. William Meehan, who's the director of our sports concussion clinic here at Children's Hospital. Dr. Meehan's going to be talking to us a little bit about concussions in young athletes.
Thanks, Dr. Proctor, and thanks for inviting me to be a part of this. Concussion is really trauma-induced brain dysfunction. The brain's not working properly as a result of trauma. And actually, it's a rotational acceleration or spinning of the brain, most often due to a direct blow to the head that causes that trauma. It's a functional disturbance. The brain's not functioning properly. However, it's not bruised, it's not bleeding, it's not swollen, it's just that it's not working properly, and people want to know why. A normal brain cell, like the one on the screen, has sodium on the outside of the cell. And for it to act properly, sodium has to move very rapidly inside. And at the same time, potassium comes out. At the time of this spinning or rapid rotational acceleration of the brain, large amounts of sodium and neurons throughout the brain move into the brain cell. And so you have to restore it to the outside in order to get it to work properly. What do we mean by brain dysfunction for the athletes? How can we tell this? Well, it's really poor memory. It's a blunted reaction time. It takes them longer to work through problems, things that my colleague Dr. Taylor is going to talk about later on. But that's what we mean when we talk about brain dysfunction. Younger athletes may be at greater risk in some ways than older athletes. Younger athletes experience a large amount of signs and symptoms. These are non-specific. Most of these signs and symptoms could be caused by many other illnesses, many other injuries. And so you really want to hear there was some moment in time where the brain accelerated rapidly that started all these symptoms, that caused all these symptoms. Younger athletes are at risk for second impact syndrome. It's almost exclusively described in younger athletes where they've had a concussion, they're not yet totally recovered, and they experience some other minor trauma to the brain that results in massive swelling and often herniation and unfortunately many times death. And even if they're fortunate enough not to experience one of these rare effects, there is some suggestion that it may take younger athletes longer to recover than older athletes. If you read studies performed on high school students, the mean time to recovery seems to be longer than those in college students, which seems to be longer than those in professional athletes. So it could be that younger athletes take a longer time to recover both their symptoms, but to have their symptoms resolve as well as to recover their previous brain function. And you can imagine, for those who have a long recovery, several weeks, that this impinges on their performance academically or at work. It also changes some of their friendships since they're pulled out of their sport and can take a toll on their emotional status as well.
Well, Dr. Meehan, that's a perfect lead into one of the questions that just came in, which is my 13-year-old son was diagnosed today with a mild concussion. He's been told to rest and do no physical activities and keep his brain stimulation to a minimum. This is obviously very hard to do. Any suggestions on what he can do to pass the time?
Absolutely, it's a great question, and first of all, that is appropriate recommendations for management. So physical rest, most of the athletes understand. What we call cognitive rest, where the sort of minimized brain stimulation, is a little bit harder, and that's what the viewer is getting at. Things they can do, things that don't require a lot of sort of brain function, watching television or watching movies for that matter, talking to their friends, listening to music, all those things really put a minimal amount of stress on the brain. They should avoid a lot of time online or reading or video games, but certainly watching movies and television, talking to their friends, listening to music, all those things are fine.
Great. We have another question here. Does using a protective headgear headband for soccer significantly reduce the risk of concussions?
No, probably not. You know, concussion is really a rapid spinning or acceleration of the brain. Many of the times the blow comes to the jaw or sort of the front of the head where the headband's not involved at all. It could be that the headband itself will reduce some blows that are delivered directly to the headband, but most of the time you get a concussion, you're not right at the concussion threshold, you're sort of way over it, and so reducing that force a small amount is unlikely to make a difference clinically.
Great. Well, thank you, Dr. Meehan. We'll be hearing from Dr. Meehan again towards the end of the webcast, but now we'd like to go to another video vignette from the Johnson family.
The visual stimulation and the brain stimulation needed to be kept at a minimum. And that was exactly what we were told. They said, you know, probably no school for a little bit right now, no reading, no watching television. You know, of course, hearing that is one thing, and putting it into practice with a very active, athletic boy, of all things, was almost impossible. Nikki learned to knit, a lot of Play-Doh and silly putty, even card games. We would only do in like 10, 15-minute intervals, but we waited on the impact test. They just felt that the symptoms were significant enough that an impact test wasn't going to be meaningful for him. So the first 3 weeks were just a lot of downtime. You know, it was the dead of winter. Like I said, we couldn't watch a movie. If the family was watching TV, we would only let Nick watch for 5 minutes, and then we'd ask him to leave the room and go do something, play with the dog, but just try and keep him at rest mentally and cognitively. And 3 weeks later, we did do the impact test. The scary thing was, from our, you know, observations, many of the symptoms had resolved. The headaches had subsided. He seemed to be doing pretty good. But the impact test showed this was not the case at all. He started to almost vomit in the garbage can next to him where he was taking it. I was in the room with him because he was a little uncomfortable, just in, you know, was the test testing his intelligence? You know, he was a little concerned about how well he was going to do in the test. So I just stayed in there quietly, and I was concerned because I could see him listing off the side of the chair. He was clearly losing his balance taking the test, and then got quite sick. So at that point, they actually just stopped it and said, "You are not well, and you know, we'll see you again in a month."
We're now joined by Dr. Alex Taylor, who's one of the neuropsychologists at Children's Hospital with an expertise in brain injury. He's going to be talking to us a little bit about the neuropsychologic testing we just heard about, as well as some of the cognitive and behavioral impacts of concussion.
Thank you for having me, Dr. Proctor. I wanted to jump back and talk about the fact that only 90% of the people who have a concussion never lose consciousness. In addition, most cases, people who are diagnosed with a cerebral concussion, their neuroimaging findings are going to be absolutely normal. They're going to look intact. So what we're left with is their self-reported symptoms and their neuropsychological functioning, which is the focus of my conversation today. So as Dr. Meehan talked about, there are symptom clusters. Typically one finds somatic or physical symptoms, things like headaches, visual problems, dizziness, noise or light sensitivity, feeling nauseous. The emotional symptoms somebody might experience, emotionality, feeling easily upset, easily angry, irritated more quickly, anxiety, sometimes even depression. Cognitive functioning can be affected. People often report problems with attention, concentration, memory dysfunction, cognitive slowing, feeling like it's just harder or more difficult to process information quickly. And people can also grow more cognitively fatigued quickly. So you easily sort of hit your threshold for the amount of work that you can accomplish. And sleep disturbance. Now the take-home point of this slide is that all of these symptom clusters are interrelated. If you're tired, it's more difficult to think. If you're tired, you're more likely to experience a headache. So we can't treat just one of these symptoms, we have to look at the symptom constellation. Now, neurocognitive evaluation, why do we actually do it? If we rely on the report of symptoms alone, we run into two problems. One, some athletes don't accurately report their symptoms. There are several reasons why. Sometimes they want to return to play prematurely. They also might be unaware of their more subtle symptoms. So what this chart shows, if you rely on symptoms alone, you can diagnose concussion with 64% accuracy. If you use neurocognitive measures that assess memory, reaction time, processing speed, that increases by nearly 20% to 83% diagnostic accuracy. If you use both symptoms as well as neurocognitive functioning, you have diagnostic yield of 93%. Now, what are the typical findings? What do we often see? As I mentioned, problems with attention and concentration, working memory, that's the ability to remember a telephone number long enough to write it down or follow multi-step directions or commands. New learning and memory can be affected. Retrieval can take much longer. The speed of processing information can slow down, and reaction time abilities can also slow. With group data, most people show recovery within 10 to 14 days. However, as Dr. Meehan has said, in younger athletes, recovery time can take significantly longer, and this may be because the brain is in a rapid state of development. Now, what are the factors that affect recovery? Age, history of prior concussion. So those athletes or those individuals who've had a concussion or a head injury in the past often take longer to recover. There can be a cumulative effect. We don't know the exact number. We manage these injuries individually. Gender can be a risk factor. What studies have shown, and I'll jump to this on the next slide, so I'll skip down to exertion. As Dr. Meehan mentioned, it's not just physical exertion, it's also cognitive exertion. You know, if you break your leg, the doctor doesn't tell you to go for a run. If you injure your brain, you might not be able to do all the things that you were prior to your injury, such as schoolwork, homework, even playing on the computer. Psychological adjustment, so feeling anxious, getting depressed, that can slow your recovery. Having a pre-existing diagnosis of anxiety or depression, those symptoms or difficulties can be exacerbated or worsened by a concussion. A history of LD, learning disability, attention deficit hyperactivity disorder, both of those things can also slow recovery due to the fact that it's harder to compensate for your brain injury. And finally, headache history. So I want to jump quickly to gender as a risk factor. We're going to quickly go through this. What it is basically showing is that women are at greater risk for demonstrating increased cognitive difficulties and more symptoms following a concussion. The reason why, it may be due to neck strength. We're not exactly sure. It's an area that we're continuing to explore. And what are the pediatric considerations? Well, as a neuropsychologist, what we're involved in is sort of determining what somebody's strengths and weaknesses are and using those strengths to support their weaknesses. So academically, we try to build academic accommodations after a head injury by providing them with support in the classroom that both enables them to demonstrate their knowledge effectively, but also helps to facilitate their recovery.
Great, Dr. Taylor. I have a couple of questions here that really reflect back to the same thing, and that has to do with some parents are aware that the NFL and other institutions are doing baseline testing. Should this be done for high school students, and who can administer the test? Does it need to be a doctor, or can it be the schools?
Okay, so that's a really good question. Now, I believe in an ideal world, everybody who has access to baseline testing should actually do it. And in a lot of schools, or in more and more schools, the athletic training department, the coaches, are actually administering the test. So what we recommend is that commercially available products like Impact, there are several others out there, are administered at the school by someone who's been trained on the usage of that measure. We hope that the people interpreting the results of those tests are physicians or neuropsychologists who have a greater understanding of exactly what the tests are measuring and when somebody is safe to return to play.
Great. Well, thanks for your input. That was very informative. We're now going to move on to another video of the Johnson family.
I just moved to a new team, and it was a different league from the past league that I was playing in, and so in the league they had finally told the kids that you could check now, and for most other leagues it was, I think, 2 years too early to check. so it was like we were checking pretty early, and it was, I think, towards the end of the year, towards the end of the season, that we were doing a big hitting drill, and this kid, well, I still am, but I was pretty small, and this kid who was, yeah, he was really tall, like a foot and a half taller than me or something, and he just hit me really hard, and it was illegal the way he hit me, but it was still bad, and I just he like hit me just like that and kind of shoved me down, and I went back and hit my head. And I mean, I got up and I was pretty mad at him, so I went after him, but then right before I was about to get to him, I just kind of fell on the ice, and I was really hurt, and I went on the bench, and I just kind of sat there covering my eyes because the lights and everything started to hurt my eyes a bunch. And then my mom, who was in the stands, saw it, and she came and told my coach to get me off the bench. So I skated across the ice to her, and my eyes were super dilated, so she got me in the locker room and got all my equipment off, and we rushed, I think, to the hospital. Once we got to the ER and I was getting out of the car, I got out of the car and I didn't realize how totally out of it I was until I finally took a step out of the car, and I was kind of wobbly and kind of whoa, what's going on? And so then I kind of knew that this was going to be pretty bad.
We're now joined by Steve Clark, who's a certified athletic trainer from Northeastern University. And Steve's going to be talking to us about the on-field management of concussions.
Well, thanks for having me, Dr. Proctor. I appreciate the opportunity to speak on this. The first question we have is what should we look for in an athlete with a concussion? As we spoke about earlier, athletes may show the following signs and symptoms. They may have confusion. This might be exhibited by running the wrong play on the field. They may have dizziness, balance problems. They may be running differently. They may have awkward running. This may not be as evident on a team with with children developing differently, but I think it's important to understand each athlete to get this point. Nausea, vomiting, sensitivity to light, squinting's a telltale sign. Any personality changes, emotional or angry athletes that might otherwise be calm, cool, and collected, that's certainly a common symptom. And as we talked about earlier, an athlete doesn't always have to be unconscious to have a concussion. In fact, they rarely are. So, steps for on-the-field management. At Northeastern, we've got a little bit more of a detailed plan utilizing our team physicians, our certified athletic trainers on staff, and what have you. So I'm going to outline some of the basic steps of a plan. If you're interested, I'd be happy to email you our plan, or you can refer to some of the sources at the end of this presentation. Very good resources there. So step one is obviously removing the athlete from the field of play for further evaluation. Ideally, we'd take this athlete somewhere where there's fewer distractions, maybe even much less pressure to return quickly. Somewhere where you can have a quiet conversation, ideally. I say ideally because that may not always be possible. If a player is unconscious, I will tell you, you do have to treat them as if they have a cervical spine injury until they prove otherwise. And this would involve activating your emergency action plan. Step two would be a basic evaluation on the sideline or off the sideline, ideally. And this would include their symptoms, their balance, their neurologic, and their cognitive function. There's a document called the SCAT-2, Sport Concussion Assessment Tool, the second version. And again, we have that available as well. And ideally, these would be performed by a certified athletic trainer or a medical doctor if present on the sideline. Continuing with our on-field management, we want to monitor for improvement or decline in symptoms. Okay, if an athlete starts to go south, if their symptoms decline, then we want to, again, activate our emergency action plan as deemed appropriate. We want to note the type and the duration of their symptoms, and then we want to, as quickly as possible, refer to a physician for further evaluation. Most importantly, you have to have a plan, and you have to discuss that plan, and then practice that plan, knowing who's involved, everybody from a certified athletic trainer, ideally, to the parents, to the coaches, to your team physicians. I would encourage you to ask your school or your club team what is their concussion plan. If they do not have one, perhaps help in developing that. One question we often get is, what can an athlete do to mitigate concussion? First of all, of course, you have to stop playing, all right? We have to avoid further exertion and further chances for blows to the head. We spoke about second impact syndrome earlier. We have to avoid that completely. Seek medical care as soon as possible. Again, an ATC on the sideline or a physician, if available, would be great. I would encourage your school or your club to have a medical presence with a certified athletic trainer, ideally. Do not return to play until evaluated by a physician. This needs to be part of your action plan. And to the parents and the coaches out there, I think it's important to encourage education on concussion, the signs and symptoms of them. And we have to encourage a culture that allows kids to report their concussions. It sounds funny, but we do have to allow the kids to report their concussions, as Dr. Mooney said earlier. And lastly, on concussion prevention, there is no conclusive literature out there to tell us how to prevent concussions, unfortunately. Some ideas that seem to make sense: using the proper technique for your sport, tackling, for example, hitting in hockey, using proper equipment, a newer helmet, properly fitting equipment obviously is very important. And then it stands to reason, if it's the rotational forces that are causing these concussions, then proper strengthening and postural control in kids would be a great way to potentially avoid that, or avoid those forces.
Great, Steve. That was very informative. We have a question that just rolled in that really fits in perfectly, and that is, are mouth guards useful in preventing concussions?
That's a very common question. I wish they were. I wish there was conclusive literature to tell us that that was the case. Unfortunately, to my knowledge, I haven't seen anything that, any reputable research that distinctly tells us that concussions can prevent, that mouth guards can prevent concussions. We know they don't cause them, so that would be obviously, and they do prevent teeth injuries, so I would promote them for those reasons alone, but unfortunately, nothing tells us that there's a link between wearing a mouth guard and not getting a concussion yet.
Great. We now have another video of the Johnson family going over a little bit of their ordeal.
After the second concussion, I just had like a really, really bad headache for a couple days. And so we went into the doctor and they told me that since the headache had lasted for so long, it was most likely a concussion.
We're now going to move on to Dr. Karama Hawash, who's one of our neurologists who's an expert in brain injury, who's going to be discussing the post-concussive headaches, which can be quite a problem.
Thank you for having me, Mark. I'm going to talk about headaches. Headaches are the most common symptoms after concussion. Headaches do not correlate with the severity of the concussion. For example, some children who lose consciousness might not have headaches afterwards, while others who seem to have a very mild head injury start having symptoms of headaches shortly after, and the headaches can be quite severe. The headaches are often occurring in combination with other symptoms. The other symptoms are typically sleep disturbances, trouble with focus, trouble with concentration, irritability, and sleep disturbances, which can also contribute to the headaches and make it even worse. The headache with concussion is very similar to common headaches that we see with other patients, so the symptoms are not very specific to concussions, which makes it important for us to try to understand what's the baseline of the player. Did the child who had the concussion have headaches before, and whether the headache frequency increased after the head injury, which makes management easier. Management of post-traumatic headaches can be acute or chronic. Acute meaning to control the headaches right now and then, and chronic is to try to prevent the headaches from happening. The treatment has to be effective, has to work quickly, and the medications ideally should not have many side effects, and the treatment should be tailored to the particular patient that is in question. The treatment is similar to treatment of headaches, like migraine or tension headaches. Acute treatment can be with over-the-counter medication. can be with triptans that are used for migraine. There are certain considerations that have to be addressed. For example, we have to be careful as to not overtreat and produce a condition called rebound headaches, and we also try to avoid opiates that can create dependency. In terms of chronic treatment, we have several families of pharmacological agents that we can use. There are anti-convulsants, antidepressants, blood pressure medications, antihistamines, and also some supplements that have been used with some success. There is also a treatment that is not pharmacological in nature. At Children's Hospital, we have an acupuncture clinic where I often refer my patients with post-concussive headaches to with very good success. We also sometimes recommend cognitive behavioral therapy to reduce stress or tension. We sometimes recommend biofeedback or relaxation training that can help some patients who develop headaches. In terms of treatment for sleep-related problems, we focus on sleep hygiene, and sometimes we consider pharmacological treatment such as melatonin or other medications.
Great, Dr. Hawash. So we had a question come in, which I'm sure you can't do complete justice to in a short time, but it's our 17-year-old daughter suffered a concussion in December of 2009 when she was playing soccer, and she still suffers from constant headache and other symptoms like sensitivity to noise, flashing lights, cognitive problems, etc. Can you address why these post-concussive symptoms might go on for this long after a concussion?
Typically, symptoms resolve in a very large percentage of patients after concussion. In 90% of patients, they do not have any somatic symptoms. So the situation with this 17-year-old patient is different because her symptoms persisted much longer than expected. It's important to understand the baseline of this patient. Is there family history of headaches? Is there family history of migraine? Did she have symptoms of headaches prior to that? Sometimes the headache, the concussion can trigger a cascade of events that make the headache symptoms much more severe. It's very difficult to understand the exact etiology of what's happening with this patient, but it's important to treat and try to minimize the morbidity from these headaches.
Great, thank you very much. And just to reiterate that most patients with concussions do recover in a short period of time, but we do see some patients with these very complicated symptoms that really requires a specialist to treat. We're now going to be moving on to another video of the Johnson family.
I believe we did go through an EEG again after we were escalated to Children's, and there was another follow-up CT. I don't really recall the timing, but it was a couple months after, just to make sure everything was fine. And one of the best pieces of advice we were given at Children's at the time was, you know, sometimes with kids, the best indicator of how they're doing is them. You know, that we can all look at this CT scan and be concerned, but you know, he's doing really well and he's passing everything, and there's nothing that was making us uncomfortable in terms of his personality, his responses, his school performance, to make anyone concerned that those brain bleeds were anything but an instantaneous reaction to the hit and not, you know, progressing along any bad lines. So, you know, Children's was great in kind of guiding us to trust our gut and partner with them to provide the care that we really thought he needed or didn't need.
We're now joined by Dr. Ellen Grant, who's one of the neuroradiologists here at Children's, who's going to be talking a little bit about imaging and concussions.
Great. Thank you for inviting me to discuss the role of imaging in the management of concussions. The role of imaging is when there's a history of physical exams concerning, to get pictures to screen for associated injuries. In the acute setting, typically we use CT because it's very fast, in the order of seconds, and we can detect fractures and hemorrhages that would need immediate changes in patient care. MRI is used to search for a more subtle abnormality and takes a lot more time, usually 30 to 40 minutes. However, I want to emphasize here, as you've heard earlier, that in the vast majority of cases, the brain images are completely normal. Here's an example where the MRI was helpful. This is a child who suffered a concussion secondary to a motor vehicle accident, and the CT at the time of presentation was negative or normal. The MRI picture on your left shows that the brain structure itself looks normal, and on the right there's a special type of picture we use to look for the most subtle types of bleeds. And we see in that red circle a couple little punctate foci of dark signal that are little punctate bleeds that are related to the mechanism of injury. So finding these help us better understand the severity and the mechanism of injury in this patient that led to his symptoms. Another thing we hear quite commonly from the patients and from their family is, why is the imaging normal so often? As you've heard again from multiple people, that's the most common thing we see is a normal MRI and a normal CT scan. And I think it's important for the audience to understand that these pictures only look at structure. And we're not really, in most cases, evaluating the dysfunction that Dr. Meehan talked about earlier. There are a lot of advanced imaging techniques that we're working on, both different tools and different types of pictures, that is going to help us probe this dysfunction much better, so we can hopefully get a better handle on how concussions alter brain function. And in this way, hopefully we'll be able to better understand mechanisms, better assess responses to treatment, and hopefully provide better prognosis or better advice on when to return to play. Here's an example of one of the newer types of technology that are available only at elite centers. This is an MR tractography image, which allows us to look at the connections in the brain. As has been mentioned earlier as well, these rotational forces have specific types of injury, and one type of injury that you commonly see is injury to the neurons, or the connecting pieces of neurons where they connect from one part of the brain to the other. Using MR tractography, we can assess the connections, look at transient changes, and also start to understand long-term changes that are related to changes in brain behavior. Finally, I just want to end up on recognizing the special situation needed when imaging children and dealing with their family. There are concerns about radiation exposure, and there are difficulties in getting children to hold still due to the anxiety and often long scan times. A number of solutions that are in place routinely at Children's Hospital is CTs for acute evaluation, like we would use in a concussion case. All have radiation doses minimized, so we are able to still detect fractures in blood like we want to, but we minimize the radiation so that the exposure is limited. In addition, when necessary, we have MRI, which is much more sensitive with all the latest types of pictures available, so we provide the latest cutting-edge technology for MRI evaluation. In dealing with the family and the child, we need to minimize anxiety of everyone, so we work closely with child life specialists to help coach children and their families through the tests. We have videos that children can watch and scanners that they can come and see to, again, get them acclimatized to what's going to happen. We also are working, again, very closely with a lot of innovators trying to push the field forward to create different types of pictures where motion won't interfere with the quality of the image. So in all situations, we hope to provide the utmost excellence of care.
Great, Dr. Grant. Thanks so much for that information. Very interesting question that came here that I think we could probably interpret in two ways. So it says, should a child who suffered multiple concussions always have a CT scan if another concussion is suspected? And maybe you can address, should they have any scan first off, and if so, if they keep having concussions, should they keep getting scans?
And I think the need for the CT exam is a team decision, so it needs to be made dependent on the history and the clinical exam. So it needs to be a decision that is made from the team evaluating as to whether an additional one is needed. Acutely, again, we want to get a CT acutely if there's concern that there's going to be fractures or hemorrhage that would alter immediate management. Other images may be more beneficial, so particularly when you get into the multiple concussions where we suspect the MR or the CT is going to be normal, MRI may play a bigger role in the future. We start to understand the physiological changes that are associated with multi-impact trauma.
Great. Thank you so much. We're now going to go to another video from the Johnson family.
When I say that Nick's third concussion was a game changer, we could tell in the days afterwards and that night in the hospital that this was different. He was different. He wasn't responding. This wasn't resolving the way the others had. And because of our background as athletes, my husband's and mine, and my husband had concussions when he was a kid too, we knew that this aggregation of concussions was something that, you know, you can't reverse time. There's no surgical response to. There's no medication that's going to fix. I mean, the brain's an amazing thing, but it can only take so much.
So now we're back to Dr. William Meehan, who is, again, our director of our Sports Concussion Clinic. And Dr. Meehan, is there a reason that we need to worry about kids suffering these concussions and more than one concussion?
You know, yes and no. A concussion is the most common neurological injury in sports, but it's not the only one. And so if you suspect a child or an athlete has a concussion, the first thing to do is have them see a medical professional to make sure it's not something else. Athletes can sometimes get bleeding in the brain or swelling in the brain. And if they do, that is an emergency, a neurological emergency. So if there's an athletic trainer on the sideline, that's sort of the ideal person to do this. Sometimes there'll be a team physician or a physician in the crowd. But if you suspect a concussion, you want to get them evaluated just to make sure it's not something else. If it is a concussion, most athletes who sustain 1 or 2 concussions over the course of their careers will recover quickly and can go on and play sports forever, contact collision sports forever. Unfortunately, some athletes will experience prolonged recoveries, and others will have major symptoms or major deficits in their overall brain function. Athletes who play high-risk sports, particularly collision sports like ice hockey and rugby and football, sometimes will have cognitive declines after multiple concussions. Their brain function will start out at a normal or even a high end of normal level, and after experiencing successive concussions will decline and not recover as it does for most people who just sustain 1 or 2. And so there can be a cause to worry, and I would say after every one you should get medically evaluated. Lastly, since there are these concerns, people want to know, can you prevent a concussion? And there's probably a few things you can do. Most concussions, at least in American football, occur when the athlete doesn't see the blow coming. And so playing heads up, constantly having your head on a swivel so you can pay attention to what's going on around you may decrease your risk of injury. Secondarily, the concussion is due to rapid spinning or rotational acceleration of the brain. And so if you strengthen your neck musculature and even posterior shoulder musculature, you can decrease the rate at which the head rotates or accelerates after impact and theoretically decrease your risk of concussion. There's actually some clinical evidence to support that. And then finally, the fastest, strongest, most skilled player on the ice or the field doesn't get hurt as often as those who are a little less conditioned. And so general conditioning, general sharpening of your overall athletic skills will likely decrease your risk of injury.
We have a question here, Bill, and you addressed some of the sports like football and hockey. How do you prevent concussions in sports like cheerleading where the athletes aren't wearing helmets?
So heads-up play wouldn't be an issue in cheerleading, but of course strengthening the neck and posterior musculature should decrease the risk just as it does in other athletes. And also general conditioning and practicing your skills. You know, cheerleading's hard because nowadays they do a lot of their stunts 30 feet in the air. There's no net, there's no trampoline, there's sort of other athletes dependent on catching them, and so until you work out the timing of that, there's an increased risk there. In fact, cheerleading's unique in that it's the only sport where the risks of concussion are higher in practice than they are in game play.
Excellent.
The Alex Rotenberg is one of our lead scientific investigators at Children's Hospital Boston. He was fortunate enough to collaborate with Dr. Muftu over at Northeastern University, and he spoke to us about his research.
This is one representative helmet sensor system prototype. What this is actually an off-the-shelf helmet where, it's not very obvious here, but inside the shell there have been drilled in a series of accelerometers that are then connected to the fine wires also embedded in the helmet lining that then can output to a computer. And what the accelerometers do is sense head movement in all directions, and not just in which direction the head moves, but how much and how fast. And from there we can determine how much possible injury there could have been to the brain. Injury is a little incorrect. It's really how much acceleration the brain experienced, and from there we can figure out perhaps how injured the brain might have been. So the fact is that a helmet with sensors, if we do our job right, it should look just like any other helmet, except it will have some electronics inside.
You know, for viewers who are interested in learning more about concussive brain injury, there are some review articles, some landmark articles that are posted up on the website now. And for those of you who are not medical professionals, there's also some books available to help you learn about this in more layman's and sort of non-medical, non-scientific terms.
Great, Dr. Meehan. In the remaining minutes of the webcast here, we're going to address some of the questions. We've had many of them rolling in, and some very interesting ones. Next question is, how often do you think children who may have sustained an undiagnosed brain injury are misdiagnosed with some other developmental and or mental health disability?
It's a good question. I think if you asked me 10 or 15 years ago how many kids had a concussion that was misdiagnosed as something else, not necessarily disabilities, but chronic headaches or ADHD or some other problem, I would have said probably fairly high. I think in the last 5 years, there's been so much attention both in the medical literature and the lay media that I hope that it's getting diagnosed more readily. Really to lead to a long-term disability, the child would have had to sustain multiple concussions sort of over and over again, or at least most typically that's the way it occurs, and I hope that that's rare.
Certainly in the realm of more severe brain injuries that we deal with frequently here at the hospital, many of those children then go on to have long-term problems. So it's an excellent question. A lot of children who seem to be diagnosed with disabilities of attention deficit or intellectual disabilities may have had a head injury in the past. Another question Dr. Meehan is, I've heard the grading systems for concussion is no longer used or has changed. Is this true, and is there a new system of grading?
That is true. It's an excellent point. Grading systems really were immensely useful in their time because people were not paying attention, at least in the medical profession, people were not paying attention to concussions and were dismissing it. But they've since been disavowed. Basically, whether or not the athlete was knocked unconscious and whether or not they had amnesia at the time of injury was used to determine their grade, grade 1 being the least severe, grade 3 being the worst. It turns out that if you have a brief loss of consciousness, sometimes you recover more quickly than the athletes that had no loss of consciousness. And so it didn't make sense to give loss of consciousness so much power with the grading system. And it turns out amnesia, while some studies showed that it predicted the length of recovery, not all of them did. And so again, people said, these are not correlating. So now we've sort of abandoned that system, manage each concussion individually. And some of the things that help us determine is it mild or is it severe is how long does it take for the symptoms to go away? How long does it take for the athlete to recover their previous baseline function if it's available? And of course, how severe are their symptoms and how far off does the brain function drop after injury?
I think that's a very important point, and something that really has changed in the past few years is that now what we've really learned is you can't technically grade a concussion or know the severity of concussion until someone's recovered from the concussion. Do you think that's fair to say?
I think that's exactly right, yeah. No way to predict at this point in time how long it's going to take someone to recover.
So what may have seemed like a mild concussion at the time of the injury, that child can go on to have fairly prolonged symptoms, where something that seemed fairly severe, they may recover within days.
That's very true, and actually athletes who have prolonged headaches, ironically, are often the ones that are thought to have the mildest concussion at the time of injury.
Another question just in here, Dr. Meehan. Do you have any advice for heading the soccer ball and how that relates to concussions?
I do. So it depends on the age of the athlete a little bit, but for a grown athlete, 16 and older, who's fully developed or physically developed, has proper musculature, times the ball properly, gets under it, and really pushes through the soccer ball. Very uncommon to get a concussion that way. Now, heading itself is a high-risk activity. You might collide with another player's head, might collide with the goalpost, fall down afterward because you collided with the player, hit the ground, you can get a concussion that way. But a mature, physically developed athlete with proper timing who pushes right through the ball will not get a concussion that way. Younger kids, you can imagine, though, 8-year-olds, et cetera, if the goalie puts a punt in and it goes 30 yards and it's 20 feet in the air and the kid gets under it and his timing is poor and he's kind of just trying to get his head there, the ball might accelerate the head very rapidly, and the younger athletes, I think, can get concussions that way.
Great. I know So a couple of these questions coming in now are a little off your expertise per se, but just as a general question, what should I do for my child with severe headaches after a concussion? What would be your treatment paradigm in the sports clinic?
It depends a little bit. So it's a great question. It's hard to say without seeing the athlete in particular. But I could tell you about things we do in general, and then you'd have to talk to your physician about what you should do for your particular case. In the beginning, first few days, we always start with just physical and just cognitive rest, because most of these athletes will have full resolution of their symptoms fairly quickly with that. When you get to about the 3 to 4 week mark, if they've improved markedly, we still might continue with only that. But if they're really having significant headaches that are interrupting their ability to perform at school or at work, then we'll consider starting medications. For me, again, it depends a little bit on their history, but probably the most common medication I used to start with is one called amitriptyline. I should caution people, it is not FDA approved for this particular indication. It is approved to treat depression at much higher doses. We'll use it at very low doses to treat headache, even what they call complex regional pain syndrome and some other things. We use much, much lower doses to treat that than we do depression. If that doesn't work, there are other medications that Dr. Hawash went through that are also available.
Great. We have another question just in, which I think would be of great interest to a lot of the audience. Obviously, concussions are very common. Not everyone who suffers a concussion is going to end up coming to a tertiary care center like Children's. A lot of them are going to be seen by their primary care doctors. So when should a patient with a concussion be referred to Children's Hospital?
That depends. You know, concussion is like everything else. And so there are going to be some primary care physicians who have an expertise in heart murmurs. And everybody in their practice knows, oh, this guy's the heart murmur guy. And if they have a question, they ask him. And I imagine concussion be the same way. You know, I suspect concussion is as common as asthma. And so I would think most primary care physicians should be familiar with the initial treatments of concussion. Having said that, I know that there are some who aren't, and I think that's okay. So I think the real person to determine that is your primary care physician. Some of them act as a team physician for the local high school. They're going to know loads about concussion. Others might not know so much. And I think most pediatricians are honest about that. And if they need help, they need a referral, then they'll give it.
Great, Bill. Another question, again, a little bit off of your discussion points here, but does the location or type of headache make a difference? And how should that influence the treatment decision? The
type of headache does make a difference. And again, Dr. Hawash alluded to this. You know, the headaches will be categorized. They're post-concussive in the sense that they started and are due to a concussion. But you can classify them according to the international classification for headaches, migraine type or tension type or cluster type. And in some ways, that can determine treatment. The only reason I brought up amitriptyline, it was studied specifically in people who sustained concussions and had headaches due to those concussions and worked. So, you know, if you're talking to your pediatrician or they refer you on to a specialist, they may tailor your headache management based on which type yours fits into.
Great, and that maybe just on the research front, Dr. Meehan and I are just starting to look at the potential association between Chiari malformation and concussion. Not that we think necessarily Chiari malformation is causative of concussions, but we do tend to see a lot of patients getting imaged for concussion having a Chiari malformation, which is a little defect in the back of the brain which can cause posterior type headaches. So that may be an area where the headaches are reflective. Okay, maybe as the last question here, as we're starting to run out of time, is isn't post-injury amnesia an important prognostic sign for recovery? You know, we used to say that, and there are 1 or 2 studies that suggest that people who have amnesia after concussion take longer to recover, but it's not reliable. There are loads of people who don't have amnesia that have very prolonged recoveries. There are athletes that have brief amnesia that recover rather quickly, and so while it can be a predictor, it's not a real reliable predictor. Great. Well, I think that wraps up what we have time for tonight. We'd like to thank you all for watching this live webcast on concussions. I believe we got to many of the questions. We will be happy to return any of the questions offline that we didn't get to on the webcast. And most importantly, remember, for the difficult concussions, we here at Children's Hospital are here to help. Through the Brain Injury Center, we have one phone number that you can call to get triaged to the appropriate specialist. We see patients here at our site in Boston, as well as at our various satellites around the city of Boston. And hopefully now you'll know when to refer a patient and know a lot more about concussions, how to prevent them, and when it could be something more serious. Thank you very much.